So this is a long list, and the reason I put this all on one slide is I don't want to go into detail on any of these. How they operate is going to be determined as we go forward. But what it shows is that Congress was serious about at least creating structures to promote this shift in payment. The Center for Medicare and Medicaid Innovation would, as I understand it, basically be a home for demonstration projects, pilot projects, to change how we pay for care. These programs will include features like ways to pay physicians and hospitals in a bundled payment framework. So the idea here is, if you think about the Virginia Mason Clinic in Seattle, which got in trouble with their commercial payers because they were doing too much testing and doing too many procedures for people with conditions like low back pain, they decided, they got religion and they decided, you know, we're going to cut back on unnecessary imaging and so on and so forth. And lo and behold, they were losing money when they stopped doing this stuff. So they worked out a deal with Aetna so that they could share the savings with the insurer when they put in place these programs to lower unnecessary testing and reduce the use of unnecessary procedures. There's not an easy way to do that in the Medicare framework. So the legislation authorizes the creation of what they call accountable care organizations, which is a way, in essence, for hospitals and physicians to band together, figure out ways to reduce costs, and get some financial rewards for doing so, so that they're not killing themselves financially when they become more efficient. So one of the things, by the way, is hospital readmissions reduction program. There is this idea that hospitals should be penalized if there are unnecessary readmissions because they screwed up or they for whatever reason, they didn't take care of the problem or people had a complication and had to be readmitted. Those that they deem as preventable will result in financial penalties for the hospitals that have these kinds of problems. The penalty is not large. It's a 1% reduction in payment. But so in a way, they put a stake in the ground here and said, we do not want to keep rewarding hospitals for not doing very well. The last thing, which I don't know if you can all see it, it's the Independent Payment Advisory Board. This was hotly contested. And this was based on the recognition, if you want to call it that, or misperception, if you want to call it that Congress is not very good at being able to make politically painful decisions, such as cutting payments to providers. So witness the sustainable growth rate, which those of you who aren't physicians probably don't really care very much about this, but the SGR is this formula by which Medicare payments to physicians would have to be cut year after year. And every year, Congress has said we're not going to impose the cuts, and they put in place payments. Well, this year, actually, Congress has not yet reached an agreement on how to fix the SGR. So there's, I think, 23% cut that's gone into effect. CMS is holding off on processing claims because they still expect Congress to do something to reverse this schedule cut. But my point is simply this. Congress saw the need to reduce the growth rate in physician expenditures under Medicare, yet every year when and so they passed the legislation, yet every year when they've had to impose the cuts, they've backed off. So the idea is you create an administrative entity that has special structure when it comes to legislation that's independent and can make recommendations to cut expenditures under certain circumstances. And this is one of the more arcane parts of the law where it describes exactly how this works. But if I could, I'm going to give you a grossly oversimplified version. It's basically if Medicare expenditures grow at too high a rate, this board is authorized to make recommendations to cut expenditures. And Congress, under these conditions, Congress will have to give an up or down vote on the bundle of expenditures. On the bundle of recommendations without any modification. It takes a 3/5 majority to overcome this and amend it. So this gives it real teeth as far as Congress is concerned. And by the way, it goes into a lot of detail about the committees of jurisdiction and how the committees have to operate, et cetera, et cetera. It's basically a fast-track status for this committee's recommendations. Now, Congress did not want to go all the way with this. The House basically hated this idea. This was in the Senate bill, and part of the negotiation was about whether to keep this in. And even in the Senate bill, this committee was not authorized before 2018 to make any recommendations that would affect payments to hospitals. Well, I don't know about you, but I think if I were worried about cutting expenditures, I might want to look at the single biggest category of expenditures in thinking about where to cut. So clearly, there's a little bit of political issue here that says this Independent Payment Advisory Board cannot be too powerful. And so there are some apparent contradictions, yet it's in there, and I think that this is a major, major change because many people thought nothing like this could ever be legislated.